Thank you for inviting me for this series of talks on pediatric upper limb problems. I think I gave one of the earlier talks when the series began about treatment of supracondylar fractures, typical fractures, very long back amidst the COVID pandemic. And when you asked me for the topic, I thought this time I'll talk about atypical supracondylar fractures, tips and tricks for reduction and fixation of atypical supracondylar fractures. So to understand how we are going to manage atypical supracondylar fractures, it is important to know what do we mean exactly by atypical supracondylar fractures. So there is no textbook definition or there is no literature which describes these are all the fractures which are atypical. So what I've done is if you leave out all the typical supracondylar fractures, rest all forms in a group called atypical supracondylar. So what is a typical supracondylar fracture? In my opinion, any straightforward supracondylar fracture which can be reduced and pinned with the two lateral divergent wires, which is considered to be the standard of care, is a typical supracondylar fracture. For example, this one, though the X-ray looks grossly displaced, so this fracture can be stabilized, reduced and stabilized by close reduction and percutaneous pinning in this fashion with two lateral divergent wires, which are rotationally also stable. So this, in my book, is a typical supracondylar fracture. So then what do we mean by atypical supracondylar fractures? We have a set of different fractures. The first one is rotationally unstable fractures. So we'll see examples of each of this. This will be more like a case-based discussion or a lecture rather than a didactic lecture. The second group is a reverse or a medial oblique fracture patterns, which typically needs a medial pin. You will not be able to stabilize with two lateral wires. The third fracture is fractures with comminution. Again, you need additional techniques of fixation or associated fractures like intracondylar extension or associated medial epicondyal avulsion fractures. The last part is flexion types of supracondylar fractures, which are quite rare, and the pulseless supracondylar fracture. So for this particular talk, I'm not going to talk about the supracondylar fractures with vascular or neurological involvement. So let us start with the rotationally unstable fracture. So this was like a 12-year-old boy who came with a posterolateral supracondylar fracture type 3. With you can see the hematoma on the anteromedial aspect. So this was reduced, closed, and stabilized with two lateral wires. And this is the external rotation view. Good reduction and fixation looks okay, but when you internally rotate the same limb and take the internal rotation oblique view, we can see that there is opening up anteriorly. So these fractures are rotationally unstable. For reducing these fractures, we have found that a derotation wire in the proximal fragment really comes in handy. This was one of the earlier cases. So we recommend that the wire should be lower down, just above the fracture site is a safer zone. Going higher up can risk the radial nerve injury. So you rotate the fragment and then place the medial wire. Once you place the medial wire, the fracture is really stable. This is the external rotation oblique view, and internal rotation, there is no opening up of the fracture. So this is a typical example of a rotationally unstable supracondylar fracture, which can be reduced and stabilized with a derotation wire, either in the most often in the proximal fragment, and sometimes you might have to put a wire in the distal fragment also. So you have to understand that every fracture is unique. So the same type of treatment does not suit all fracture patterns. This is the example for a reverse oblique fracture pattern. So you can see that the fracture is going high up medially and then coming down lower down on the lateral side. So this fracture is impossible to stabilize with two lateral wires, and this was fixed with two cross K wires. So this was stable rotationally also after just two cross wires. And this is the 4 weeks postoperative X-ray which went on to heal well. This is yet another medial oblique fracture in a slightly younger child. So the other option to stabilize these fractures, so this was difficult to get even a single lateral wire. You can see that the fracture is exiting distally. So we used the Dorgan's technique of putting lateral wires to stabilize the medial column. So these pins are called as Dorgan's pins. You come from the lateral side to stabilize the medial column. And this is the 3 weeks follow-up and went on to heal well without any varus collapse and a longer follow-up of the same patient. So you have to be, though Dorgan's technique is good for stabilizing the medial column, so you are protecting the ulnar nerve, you should understand that it's a trade-off. So if you, there are reports of radial nerve injury using the Dorgan's pin. So one should be beware of this complication, possible complication before attempting to put the wire, and one should be aware of the anatomy of the radial nerve while trying to do the organ spinning. Let's go to the next set of fractures, which are comminuted fractures. So it is not uncommon to see comminuted fractures these days, because we do see children with high violence injuries. There's a 9-year-old child. You can see that the fracture pattern is a reverse oblique fracture pattern, and there is a distinct butterfly fragment, a huge one on the medial side. Again, this small external fixator comes in handy for us to stabilize these fractures. This is what is available in our setup, which is called the JES fixator, Josie's external stabilizing system, wherein you put KYs, and this fixator is really handy, which maintains the length of the fracture and alignment as well as the rotation. So we place the medial wire and place this external fixator to stabilize the fracture, all done percutaneously without opening the fracture site, and we just have to maintain the alignment and the length. At 1 month follow-up, you can see that the fracture has went on to heal well. As you move up higher, when you see adolescents, more of high violent injuries are seen in this age group between like 12 and 16. And these fractures can sometimes be really difficult to deal with. So this is a really badly looking comminuted fracture of the distal humerus, or a supracondylar fracture, as well as a Salter-Harris type 2 injury of the distal radius. So it is impossible to stabilize this sort of fracture in an adolescent with just KYS. This is one of the indications to stabilize either with a plating or an antegrade or elastic nailing. We opted to do an elastic nailing of the humerus, distal humerus, with the proximal entry, and stabilize the distal radius with the percutaneous spinning. So this is how it was done. Reduction was not difficult. Getting the alignment was okay. When we placed the lateral wire, the lateral nail went on well, but there was a little bit of varus of the distal fragment due to the comminution, which was corrected using a joystick of the distal fragment, and then the medial elastic nail was placed. So we also did an arthrogram to confirm that there was no intra-articular extension of this fracture. This is arthrogram picture. There was no intra-articular extension, and we were quite happy with the alignment as well as the stability with just 2 elastic nails. And this is the post-operative X-ray of the patient. The distal radius spinning also went on well. And I do not have the follow-up of this patient. This went on to heal well without any major issues. This is the 2 months. So 2 months follow-up is the latest one we have. And moving on to the next set of atypical fractures is associated injuries. This is an 8-year-old child with a fallen outstretched hand. You can see that there is a comminuted supracondylar fracture, but one should be not miss that there is a fracture line seen, which is coming from the olecranon distally down. So this is sort of an intracondylar fracture, which is not quite common when you see supracondylar in younger children. Less than 10 years, intracondylar extension is quite rare. It is important to pick this up. When you miss it, you can have problems later on. So this fracture was reduced and fixed, and then we did an arthrogram to look at the articular congruity. So the fracture was reasonably reduced, and there was no articular step up. So we decided to do it percutaneously with a K wire, and that was how it was fixed. And this is the 1 month follow-up of the patient, which eventually went on to heal well. In an older child, when you have intracondylar extension like this, you can see that there is a intracondylar extension into the lateral condyle here. It is better off to put screws rather than just wires. So this patient was treated with that wiring for the pinning for the supracondylar fractures, and then a screw fixation for the intracondylar fracture. The next type of fracture is the flexion type of fracture, which is quite rare, but it is important to recognize these injuries. So the incidence is about 2% of supracondylar fractures. Why is it important to recognize it? That these fractures can be difficult to reduce by closed means, and oftentimes they may need open reduction. It is important to discuss this aspect with the parents, that these fractures might need open reduction and internal fixation rather than a closed reduction and fixation. And this particular patient, this is the C-arm pictures. When we tried to reduce the fracture, we thought that it is the proximal fragment was rotated. So we used a wire to rotate it back, and luckily we found that when we rotated the proximal fragment, everything aligned well in the lateral view. And this is the AP view also. The fracture looked aligned, and we just fixed it with 2 wires. But what was interesting was there was a fragment anteriorly which we could see, which is, we thought it's a comminuted fracture, but it was a medial epicondyle avulsion fracture, which was held with a K wire and then reduced back to place and percutaneously fixed with a K wire. So this is a flexion type supracondylar fracture with the medial epicondyle avulsion, which was reduced and fixed with percutaneously with 3 KOs, 2 lateral divergent wires and one medial wire. So this was the final fixation. We are happy with the alignment both in AP and lateral views. And this went on to heal well without any major issues. So as I said, flexion fractures can be tricky sometimes. This is a 9-year-old girl. So it was looking like a flexion type supracondylar fracture, and we thought that it is going to go on well. And I asked my fellow to go and reduce and pin it. We missed to discuss with the parents that this might need open reduction. We told that we are going to reduce and pin it. Reduction was not difficult. The fellow said that it is he was able to reduce the fracture, but then the stability of the fixation was not adequate. We are not able to get a stable fixation by percutaneous methods. So this was a difficult fracture. When I went back and into the OR, opened up the fracture, and we saw that there was lateral comminution and there was avulsion of the muscles as well. So we had to suture it and then secure the fragment to the main fragment. But then the medial reduction was not satisfactory. So this actually needed a medial open reduction as well to get a good reduction and stabilization. So this was the final fixation. So since there was a bit of a struggle, we thought we'll not leave the wires percutaneously. So the wires were buried inside. And then immobilization was given for 3 weeks, and then we started gradual mobilization. Luckily, she did not have any sort of infection, but by 6 weeks, we saw that the elbow was quite stiff. She was not gaining range of movement. At 5 months, we removed the wires, and you can see that there is some sort of avascular necrosis changes happening in the distal fragment. And the last follow-up range was about 20 to 130 degrees. So this is not a very typical sort of a supracondylar fracture. This, I felt that it is more of a transcondylar fracture. You can see the fracture quite low, and these fractures are more unstable, and you could face challenge in stabilizing them percutaneously, and you should counsel the parents for a need for open reduction as well as the higher chance of stiffness as well as avascular necrosis. These are very low supracondylar fractures. There could be vascular insult and they can be avascular necrosis. This is the last follow-up, about 1.5 year follow-up of the patient. She has a decent range. Function-wise, it is okay, but no, the X-ray is not looking very great. But for the injury, I think this is a reasonable outcome. So every supracondylar fracture has to be treated with caution. We cannot say that, oh, it is just another supracondylar fracture, and we advise close reduction and pinning. So this is a 4-year-old child with a typical fallen outstretched hand and a supracondylar fracture. When the resident attempted reduction by the routine maneuver of flexing the elbow, this was a C-arm picture. So this is an unstable pattern of fracture where your posterior periosteum is also torn. So this is a type 4 supracondylar fracture, and one must be aware of this possibility, and we should not flex it without having a C-arm image. So this fracture has to be, then the elbow has to be extended, aligned well, and then fixed with 3 lateral divergent wires. Eventually, it went on to heal well. So why did this happen in the first place? As we discussed already, these are type 4 supracondylar fractures where your posterior periosteum is also torn. So the question is, can we predict, is there any way to predict that preoperatively? Because preoperative imaging says it's a type 3. How to diagnose a type 4 supracondylar fracture preoperatively? There is a nice article which was published in JBJS in 2019, where they have found that there are substantial radiological signs. So there are some radiological features they have described which could be suggestive of an unstable supracondylar fractures. And these radiological signs are flexion angulation of the distal fragment. So whenever you see flexion angulation of the distal fragment, you should suspect that it could be a type 4. Valgus angulation, lateral translation. You can see in this picture, the third picture is a complete lateral translation, or osseous opposition. So these 4 radiological parameters, whenever you see in a supracondylar fracture, you should be having a warning bell that it could be a type 4 supracondylar fracture, which is potentially more unstable, and it could be challenging to reduce and fix. So whatever I've discussed in this talk, we have written as a narrative review article on atypical supracondylar fracture, and this is the QR code for the same. To summarize, there are various patterns of atypical supracondylar fractures, which one can come across in the day-to-day practice. First of it is the rotationally unstable fracture. These fractures you may be able to reduce with the derotation wires, and oftentimes it needs a medial pin to stabilize these fractures. The second pattern is a reverse oblique fractures, which will need cross pinning or a Dorgan spin. And whenever you have comminution, you might have to choose other types of fixation, like a mini external fixator or a just fixator, or sometimes TENS, and even in adolescent patients, you might have to think about plating these fractures. Whenever there is an intra-articular extension in adolescents, it's a good idea to take a CT scan to know the fracture pattern, and arthrogram comes in handy in these situations to look at the articular congruity. You may be able to get close reduction sometimes, and if you don't get a good close reduction of the joint, it needs open reduction and fixation with screws or wires depending upon the age of the child. And finally, about the type 4 fractures, which are unstable in all the directions. It's called multidirectional unstable fractures. There are subtle radiological signs by which you can recognize these fractures and be prepared to reduce them and fix it. Thank you very much.
Thank you, Venkat. That was a very nice, elaborate description of atypical supracondylar fractures. And I always remember you fixing supracondylar for my son many years back. And he actually can't make out which side was injured, so he's doing very well. It is one of your long fracture. So we have one question in the chat box by Dr. Saldado. He is asked, what are your indications for putting plate in a supracondylar fracture?
So intra-articular fractures, whenever there is an intra-articular extension and comminution in an adolescent age group, maybe like 14 plus age, then I think about plates, 14, 15 years. In an younger age group, if I am able to get away with pins, we try and fix it with pins. So yeah, adolescents are, I think, adolescent pediatric fractures are a different ball game, and we need to deal them as a separate group of fractures. The rules are different for fixing those, even all fractures for that matter, not only supracondylar fracture. And somebody has asked, when do you start mobilizing?
Yes.
So typically, if it is less than 5 years, I immobilize for 3 weeks. If it is between 5 to 10 years or 5 to 12 years, 4 weeks of immobilization. I'm a little more conservative. So 4 weeks of immobilization is what we practice usually.
When you require to put this medial pin, do you try to see the ulnar nerve and put, or you have any other tricks to prevent any injury to the ulnar nerve?
Some people say that it is a good idea to do a small opening and protect the ulnar nerve, but I do not do the mini open technique. So we usually keep the elbow in extension. If we flex the elbow, the ulnar nerve translates anteriorly. So we make sure that the elbow is in extension, and then we will be able to palpate the medial epicondyle even if there is swelling. Most of the times we put a little thumb there and push the nerve posteriorly. I use the wire in the hand, pierce the skin, go to the bone, and then connect the gun and then drill it directly. I don't just place the wire and then drill it blindly. I feel that it is a safer option to do that way. So some people have described using a drill sleeve as well.
Yeah, that's interesting. Any other questions from the participants or the faculty? Dr. Dan, would you like to give you any comments on the talk?
Sorry, I'm getting on. I'm in the middle of breakfast. Yeah, it was a fantastic talk. I think, what's interesting about these fractures is that they are, well, you can be fooled into thinking that they're just a regular supracondylar. And one of the comments you made is that you didn't talk to the family about having to do an open reduction. And I say that even the most basic supracondylar fracture, we always put that on our consent. And I think that sometimes you don't know what kind of enemy you're going to be facing. And you guys have a tremendous amount of experience compared to me. So, but I think that that's something that you always have to keep in the back of your mind. I've certainly been surprised by things that looked pretty reasonable. And then you get in there and you can't get it reduced because there's something in the way. Yeah.
Yeah. So there is one more question. Somebody has asked about the Dorgan pin. Any precaution with the Dorgan pin? Yeah, definitely there is a risk of radial nerve injury. So if you start from slightly anterior and go posterior, that is one of the ways described. So there is a nice cadaveric study, an article published in Journal of Pediatric Orthopedics. They've done a cadaveric study to look at the course of the radial nerve in that particular area, and they found that it is safer to go from anterior, slightly anterior to posterior is a safer track. And in my practice, I do not use it regularly. Very rarely, I use it whenever there is a need. I am comfortable with putting medial pins. I don't see much problems with medial pins. And the one indication for me where I use it routinely is while during a corrective osteotomy for cubitus varus. So because we know that it is open there and we see everything there. So I use a Dorgan spins to stabilize the medial column when I do a corrective osteotomy for cubitus varus.
Okay.
I had another question about the use of flexible nails that you use in an antegrade fashion. Do you have any specific tips or tricks for the entry site, or how to guide those pins in the right direction?
Yeah, so this is one is in the C configuration, other is in the S configuration. It could be really tricky to get this one inside. I should tell the disclaimer that I have not done a lot of antegrade nailings for supracondylar fractures, maybe like a handful of them. The entry is just below the deltoid insertion, and the first nail goes usually in a C configuration on the lateral side to the lateral column. The second nail, usually we pass it and then we rotate it 180 degrees and then bend it so that you get a C sort of S sort of configuration, and then you pass it on to the medial column. Yeah.
Okay.
Thank you.
Thank you, Venkat. So that was quite
Thank you.
informative, very, very exciting.